stroke, is the assessment, just assessment of the seizure, how long and you have to ensure that it's a true post-stroke seizure, and you have to exclude other seizure means, other stroke means. So you have to exclude them. And when you get know that it's a true post-stroke seizure, then you assess there are a couple of studies that have alluded to the fact that giving statins decreases the risk of post-stroke seizures. Decreases the risk of post-stroke seizures. Whether the post-stroke seizure and statin. But keep at the back of your mind that statin. But keep at the back of your mind that statins have also been proven to actually increase the risk of a hemorrhagic transformation after an extreme impact. So it's most of the papers are from Chinese authors, but there are a couple of two papers from the US that have assessed this and found that statins actually decrease the risk of a post-stroke seizure, whether it is early or late. Yes. Thank you very much.
Yes, thank you very much, Dr. Isaac. Another round of applause to Dr. Isaac. Yes, it's really been comprehensive. And this was just part one. Yes, so we have a part two of this. I don't know what the next presenter who will be discussing post-stroke seizures part two will present, because to me, I feel this was quite exhaustive.
So the next presenter has done work around this topic in our setting. So she's going to tell us what she found, and we see if what I've said is what she found, and discuss that. So that's what she's going to present as part of her MA work to try to assess post-stroke seizures for patients in our setting at Mulago Hospital. So we shall see what we have discussed is what will come up in our presentation.
Awesome, thank you very much. I guess some of us have questions that Dr. Singora can answer, or any of our neurologists. So feel free to raise your hand, we'll bring your mic and ask your question. Yes, we shall start with Kajimu, then you pass the microphone like that after our consultant.
Thank you very much. I'm one of the people who is still not so, I can say, stable, is waiting for a patient to have a seizure, so that I can have a decision when I know that so I'm wondering the guidance, okay, the guidance is generated from causes, and did they also explore into the other people, seizures from infectious causes, and something else, like are they applicable, especially seizure prophylaxis,
Yes, thank you very much, Dr. Akaji. So, that first recommendation is the recommendation most guidelines give about post-stroke seizures, that primary prevention has no role, doesn't improve anything in terms of outcome. So if you get the anti-seizure medication, it doesn't improve anything in terms of outcome. And specifically, the guidance from the International League Against Epilepsy was derived specifically from patients who have gotten post-stroke seizures. So this guidance applies for a patient who has gotten a stroke. You You don't have evidence yet that they have a seizure, and you're trying to ask, should I give them an anti-seizure medication? And the guidance is giving them an anti-seizure medication for primary prevention when you don't have evidence that they've had any kind of seizure does not help in any way. And there are a couple of studies that have, I can share into that paper, there are a couple of studies that they quoted that evaluated mortality, evaluated functional outcome, evaluated disability, evaluated the risk of getting post-stroke epilepsy, and the group that got anti-seizure medication as primary prophylaxis didn't differ to the group that did. So the guidance is do not give it.
I think most of the studies I came across, they were mostly dealing with that. Okay, like we tackle the other causes, like traumatic, I saw it was traumatic. And then, if you, yeah, most of them, I'm thinking about the line of
So this guidance doesn't apply to other causes of seizures. This guidance is specifically for a patient who has gotten stroke. And the papers from which this guidance was derived looked at patients with post-stroke seizures, and in those cohorts, the cohorts of patients, the European cohort, there was another from I think Michigan, and in those patients they specifically excluded patients who had an alternative, a second cause of the seizure. So I do not know if it applies to if you have trauma. I do not know. I know there's neurosurgeons like to give primary prophylaxis for seizures. So I do not know if it applies to trauma. I'm not looking at that. I do not know if it applies to infectious causes. If you have TB meningitis, you give primary prevention of a seizure. I do not know if it applies to that, but it does apply to a patient who has had a stroke. So for you to have a post-stroke seizure, you've excluded those. So you've excluded your hypocalcemia, hyponatremia, uremia, you've excluded those.
Thank you, Dr. Sigura. I'm reducing it from the last comment you gave on the use of statins. And these patients who have had stroke, and we looked at the cohort where the risk of transformation, then the one in the US which was opposite. There is also a paper I came across where they said you can weigh like, if the patient has a risk of myocardial infarction, other things like that. But the reason for my question was what is the evidence in our setting of constipation?
I'll leave that question to the neurologists. But what I can say, if the patient qualifies for a statin, you give them a statin. So when you get a stroke patient, one of the things you evaluate for is the mechanism of the stroke. So if the stroke is from an atherosclerotic cause, the patient would definitely benefit from the statin. And you'll find that most patients with ischemic infarcts in our setting receive statins, and that's an international recommendation. The only trouble has always been what's the best time to give the statins. And there's data that says, you know, high dose statins should be prescribed early in an acute ischemic event, the same way it's prescribed early in an acute myocardial infarction, to give a really high dose of the statin and to try to utilize its immunomodulatory function. And that has been shown clearly in acute myocardial events from atherosclerosis that it does help. So in stroke, people have shown that there is a risk of hemorrhagic transformation. So do you do that? Don't you do that? Maybe I'll defer that question to the neurologist, our bosses. Thank you.
Yes, thank you. My question is about thank you, Dr. Tilesina, for the presentation. My question is about the definition. For instance, if you have a patient who has had a stroke, but then presents with seizures within 2 weeks, and most times we do our imaging to rule out either hemorrhagic transformation or a new onset stroke. So would I qualify my patient in case if they've had a stroke, they've been on treatment, and the risk factor has been controlled, maybe the hypertension. So in case they get a new onset seizure, and on imaging, I find either a new infarct or and then whether I get a new infarct, so would I categorize them as a post-stroke seizure, or I would attribute it to probably the infarct that has come in? So my question is, do those patients with recurrent strokes categorized as post-stroke seizure if you've excluded maybe the hemorrhagic transformation? So I don't know what your comment is on that question. And then the last one is on the left seizure, what you talked about long-term management for such patients. I wanted guidance on to what extent is it for life, or is there a criteria where you keep monitoring them whether they have episodic seizures before you decide to either hold treatment or it's for life? Thank you so much.
Thank you very much for the question. So if you have a stroke and you get the seizure, this is the simplest, easiest kind of flow you go through. So if there is any reversible cause you identify, correct the cause. If there is no cause, you classify it as a post-stroke seizure, whether the patient is having a recurrent episode of a stroke or an index episode of a stroke. It doesn't matter. You still classify it as a post-stroke seizure and classify that it's an early seizure or a late seizure. In terms of if a patient has post-stroke epilepsy, do you continue the anti-seizure medications for life? And this is a question that has been asked and answered for patients who have epilepsy. So for your normal patients who have epilepsy, the International League Against Epilepsy has a criteria for considering the epileptic drugs. So I did include it in this presentation. I did come across studies that have tried to ask and answer the same question if the patient has post-stroke epilepsy. Post-stroke epilepsy is the most common cause of epilepsy in adults. And their guidance is that it doesn't apply to post-stroke seizures because they take a longer time to resolve because you have an epileptogenic focus. So they came up with they came up with a tool, a guidance tool. I didn't really include it. It has like 20 parameters, and it's meant to guide clinicians on when to stop the anti-seizure medication. So obviously the anti-seizure medications are quite problematic in the old or elderly population compared to the 24-year-old epilepsy. That one, the side effects may be not as much, but if you consider a 78-year-old with post-stroke epilepsy, do you give them the anti-epileptic drug for the rest of your life? So there is a tool, it's called, I came across it, it even slipped my head. It's called an epilepsy stamp, but there is a tool that aids clinicians. I can look it up and share it with you. It has 20 parameters, so I found it not very palatable to use. Yes, thank you.
Thank you.
Thank you very much, presenter. I actually attended a conference recently where we were told that when somebody has done a good job, if you have intent to clap, then actually clap. So when it is time to applaud, let's applaud. Yeah, and I think this presentation to me is quite timely. Mine may not necessarily be questions, but just a few comments for practical purposes picked from the presentation. One thing that I think, although not completely resolved, has at some point given us some guidance on this anti-seizure medication for patients who have had stroke and have not had seizures. I see a lot of patients on my ward who have been started on anti-seizure medication because they had either one seizure or they are feared. Like this gentleman was talking, I think he's very scared about his patient getting a seizure, even if they haven't had one. I also practice along surgeons in some places, and their threshold for giving anti-seizure medications is quite low. So if you are with them, you are likely to be giving this patient. But I think, like he said, we are trying to see evidence-based practice. And I think it would be wise for us to go along with this guideline. A patient who has not had a seizure post-stroke, probably we shouldn't initiate prophylactic anti-seizure medications. That is something that I think has come out clearly. I hope I got it right. The other thing was, may not necessarily be related to, but he talked about patients who get seizures which are not convulsive in nature. Non-convulsive seizures. Yes, this is something that happens quite frequently, particularly in patients in the ICU, and usually people miss these patients. You just see a patient whose level of consciousness is not improving, and yet you are doing everything you can. Please be keen on looking at the possibility that this patient may be getting seizures that are not overtly happening for you to see. And look out for these subtle signs. Even the attendants can be asked to look. There is episodes when they get episodes of like latent breathing. You can look at their eyes. These kind of things can help us. Of course, we then go and do an EEG. But quite a number of patients get non-convulsive seizures, particularly those who are very sick and they are missed. The other thing which I think I picked out is the issue of, of course, when a patient gets a seizure after a stroke, in the early stages, we treat the seizure symptomatically, not with the aim of continuous anti-seizure medication. Symptomatically, we use the usual drugs. Here, what I wanted to mention is that what we have in our setting mainly is phenytoin. But recommendations, at least that have come across, tend to discuss the use of IV phenytoin, and preferably levetiracetam is the drug of choice. Basically, because phenytoin has other interactions with the other drugs that we are using for these patients, and probably it also has some effect on the changes that may predispose the patients to get more seizures. That is something I came across. I don't know whether it has come out also in what you have looked at. And then the other thing which I wanted to talk about, which is, of course, arises from his concern about, or was it him or somebody else who talked about, you think of stopping anti-seizure medication for people who have got seizures or epilepsy post-stroke. Now, like he said, we have guidelines for stopping anti-seizure medication with patients who have epilepsy. One of them, of course, is what he talked about, the duration when the patient has been seizure-free. But there are other guidelines which would give you an idea whether it is safe in this patient. the likelihood that the seizure will not recur. There are others. If the patient has focal neurologic deficits, if the patient had an abnormal EEG, and of course if the patient had an abnormal imaging, the chances of being seizure-free when you stop the medication are less than that patient who doesn't have these things. So all these things come into consideration. And of necessity, really, people who have structural lesions as causes of seizures are more likely to be difficult to manage and control the seizure. So have this in your mind. Thank you very much.
Thank you for the presentation. It was really exhaustive. Dr. Motobe, thank you for those comments. They address most of the things I wanted to comment on. Still, you've stolen 70% of them. So just again to clarify on the question the gentleman you asked, and I'm representing the little people. So it's been adult neurologists, but there's a number of us for little people. Maybe the introductions will be made later at an appropriate time. But yes, children also have seizures, even neonates. Actually, the pediatric population, the neonates get more seizures, even more than the older children. And most of the guidelines are picked from adult data, but we have some clear-cut things that I think go along. As far as prophylaxis in seizures that are symptomatic, we've talked about stroke, but he had brought up something on trauma, he had brought up something on infectious causes. Even for those, there is no evidence at all for starting prophylactic anti-epileptic or anti-seizure medications. So if your patient has had trauma, at least in the little people, in pediatrics, trauma, an infectious cause, encephalitis, whatever, as long as they've not given you seizures and you've not seen seizures, you don't start prophylactically. Anti-seizure medications have their side effects, and then some of them also have effects that may hinder following up your patient. You sedate them and then you cannot follow up on the course of their real neurology. So the goal is in assessing your patient, being killed. Once you see a seizure low, have a low threshold of managing it symptomatically. So for us, we make things easy in case you ever have a child. So there's early seizures, late seizures. For us, we call it symptomatic. Any seizure that happens in the context of something, a cause, it's a meningitis, it's an encephalitis, it is trauma, it is stroke. As long as it's within the context of something caused it, yes, abort the seizure, but manage the underlying cause. And then you don't keep those children on anti-seizure medications. You can load if it's status, don't even maintain in that context. Watch. If they're having bad seizures, then you may maintain, but for a short time that you would decide as you follow up your patient. And then when it comes to answering partly what she was asking, epilepsy, and I think for you those are the late seizures. So you either decide whether your patient has now got epilepsy from whatever happened or not. If you decided your patient has epilepsy, and the ILAE gives us different definitions, but these ones lie in the definition of those that even if it's one seizure, but the fact that they have a lesion that correlates with your seizure, the semiology, how they're convulsing, your EEG, even if it's one, then you have a 60% chance of recurrence. So you decide it's epilepsy, I am going to treat. Now for the little children, we have a clear cut. It doesn't matter what it is, apart from a few genetic epilepsies, where we'll say that one, the chances are very high, keep them on for life. But even with stroke, once we make 2 years seizure-free, I think for the adults, it is 5, the extent. But if you made it 2 years seizure-free on your anti-seizure medications, patient has no seizures, you're either in remission like the doctor said or not. So we treat the patient, not the fear. So for us, remission, 2 years, seizure free. I think for the adults it's a bit longer, he said 5. Wean off. Give that patient a chance to be off medications, regardless for us of what EEG is like or anything, as long as clinically they are no more seizures. 2 years on medications, we know what is the worst that can happen. If their chances of recurrence are high, even in stroke, the worst that will happen is they will have a what? Another seizure, okay? And then you can put them back on medication as failed weaning. And then you try another 2 years or 1 and see. If again they behave, no seizures 2 years, give them another attempt. Because there's drug burden, there's side effects, there's a lot of things. And along the way, people get a lot of other diseases. So if you can reduce their burden. So if you try the second time and still they cease weaning, that's when we say, you know what? I think you make an executive decision as a clinician. You're like, I think let me leave this one on for life. We've given you an attempt at weaning twice. Every time we withdraw, you get a what? A seizure. And then, yes, also just make sure, like you said, there are no other things that are happening as seizures. And then we think we are treating seizures. Yes, thank you.
Thank you very much for the comments. I really appreciate that, Doctor. And thank you very much, Dr. Mato, for the supplements. So my presentation ends here. I hope you've learned a thing or two. Yes, thank you very much. Over to you.
Yes, thank you very much, Dr. Isaac. I think we've learned quite a lot. And we've learned that we have a pediatrician in the house. So to avoid missing out on any other key people that we have here, I've been requested that to allow you a second to introduce yourselves. List your name, your cadre, your SHO, your intern. And as of today, as of now, everyone here is either neurologist or neurologist in the making. So, for instance, I know you have neurologist in the making, Emmanuel here. But I shall allow you a second to introduce yourselves as we prepare for the next presentation, which will be about more of the same, but about work that has been done here. So, I think I'll start with my right here. We've already known Dr. Isaac, so we shall proceed. We give you a mic, tell us about yourself in just the shortest time possible, and then we shall get to the next presentation. In the meantime, I'm going to cast our code here. We have a WhatsApp group where we posting some of the pictures here, some of the literature, and I think we shall also have some of the slides posted there. So in case you're interested, feel free to scan the code and be part of the group. And then also we are streaming live. Yes, we've shared the link in that WhatsApp group, so feel free to share the link to any other person so that they can join in and they follow the discussion. And I think we're being a great audience, so let's do the self-introductions and then we shall go to the next presentation.
Thank you very much. Good morning, everyone. Today, Andrew, I'm SHO, for Internal Medicine.
Good morning, everyone. My name is Jumba Moses, Internal Medicine resident, year 2, Ontario University, Mulago.
Good morning, everyone. My name is Jacob Senkondo. I'm SHO year 3, Internal Medicine, Ontario.
Yes, I'm Halima Naiwumbe. I'm a pediatric neurologist based at Mulago. Good morning, I'm Joyce. I'm a pediatric neurologist as well, based in Zambia. Also allow me to pass on Mr. President because he has apologies. His contact with the Friday Clinic. He says I tell him he did do one last week, so he had to try and join us. He also requested that I introduce the young group of the pediatric neurology in this. So it's Halima, pediatric neurologist, and myself. And then Dr. Karash is going to introduce herself. Neurodevelopmentalist, our first in the country. All right, thank you.
Dr. Kayan Adrian, neurophysician, University of Science and Technology, and Mbarri General Referral Hospital.
John Baptist Mpati, internal medicine resident as well.
Kantura Nato, SHO3, Lago.
At the Isaac, resident as well.
Teacher Fahim, internal medicine resident Tier 1 from Lago.
Kawamba Imelda, internal medicine resident Tier 1, Lagos.
Dennis Moyo, SHO3, Monaco.
Anino Kevinator, Yafri, Monaco, SHO.
Mubarak Kaira, SHO2, Makerere University.
Okay, thank you very much. I'm Dr. Stephen Mwongi. I'm a senior consultant physician practicing neurology for the past 19 years. I'll make a comment also on behalf of this federation. Glorified, is it glorified or? I'm very happy anyway to see that we have a number of people here. The number that we have discussing neurology is something that rarely happens. When this federation started, of course, among the many things that we wanted to do was to demystify neurology as a practice so that we get more people on board. And hopefully with this kind of gathering, we are beginning the process of demystifying this subject so that we can have more people to take on the mantle for some of us who are retired. So thank you very much for coming, and we hope that we have generated enough interest along the way to have some of you stay behind, because oftentimes we identify people and we think they're going to join us, then when they finish their postgraduate, they disappear. So please, some of you stay around so that we can put hands together.
I'm Isako Fredason, and medical officer. Maybe to add a comment on the next part of the list is neurology is very difficult. So
that's what we're trying to say.
Morning, my name is Sheila Nasso. I'm an internal medicine resident at Lab.
Morning, my name is Sankai Enoch. I'm here to terminate something.
Good morning, I'm Dr. Mseli Shafik, internal medicine resident Tier 1, Makerere University.
Good morning, Pius Baruji, SHO2, internal medicine.
Good morning, Asharia, internal medicine, Mulago, SHO1.
My name is Nuha Ziyad, SHO1, internal medicine, Makerere University.
My name is Emmanuel. I'm a JHO on 4B neurology, female side. Neurology is in the making. I really feel neurology. So good.
Morning, Ndiambat and my names, and I'm a JHO neurology.
Good morning, I'm Caroline Nerima. I'm a pediatric neurodevelopmental specialist. I work at Zambia Hospital.
And I'm ready to take
Good morning, I'm Rita Sijanantondo, SHO Year 2, Mulago, Makerere. Good morning, I'm Margaret Nachiwana, SHO Year 2, Makerere University.
Morning once again, I'm Dr. Martin Kadu Kasa. I'm a consultant neurologist working with Nago Hospital.
And that's the president. Okay, our president. So we need to come last wasn't by mistake, but it was by design. So thank you very much for those kind introductions. Now that you know each other, feel free to associate, okay, interact, get to talk a little bit at things. And yeah, by the end of this conversation, make some new friends. I'm happy to see our comrades, the pediatricians. It's a pleasure having you. in our midst. So I think we should now go to our next presentation, and that will be delivered by my classmate. Yes, sometimes when she's happy, she brings in an American accent. So you're about to hear one. Yes, Dr. Bernadette Akwi will take us through post-stroke seizures in acute stroke patients at Uganda National Referral Hospital. The studies that she has done. She has about, there are people who need to introduce themselves.
Behind you.
I think it is too much. Could you have had
Maybe there was a scene.
Absolutely. Wow, very interesting. So, Dr. Bernadette, over to you.
Good morning, everyone. I'm called Dr. Bernadette Akwi. So I will be taking you through some of the work that I have been privileged to do in Uganda National Referral Hospital on my postgraduate thesis. Disclaimer, we are still compiling some of the work, so we are not fully done. But I'm going to give you some of the preliminary results that we're working with. And so I would like to acknowledge my supervisors that have been very key in this work and in helping me align this work. Professor Kadu Mukasa, Dr. Martin Kadu Mukasa, as well as Dr. Jen Nachibuka. So we've done work on post-stroke seizures, and in this study, we're basically looking at the incidence and the associated factors. It's a prospective cohort study that we carried out 30 days. So why post-stroke seizures matter? Dr. Isaac made my work a lot easier. So everyone now is almost at par with what post-stroke seizures are. So basically, he talked about stroke being a major cause of new onset seizures, especially in older adults, and increasing morbidity, which complicates rehabilitation, and it's also associated with poorer functional outcomes. So in this study, we defined seizures as at least one episode of seizures that occurs in patients who have acute stroke. So patients that had recurrent stroke were excluded from this study, and we defined early seizures as those less than 7 days, and the late seizures as those more than 7 days. And like the previous presenter alluded, so early seizures reflect to acute chemical injury, whereas late seizures reflect structural remodeling and epileptogenesis. So I'm not going to go into detail what you already talked about. And in Saharan Africa, from the recent studies, there has been a high burden of stroke. And we believe that the high burden of stroke puts these patients at an increased risk of developing stroke seizures. But in our setting, the burden is under-characterized, and we also be amplified by delayed presentation and resource constraints, like we are going to see in so this study our study objectives were to determine the incidence of post-stroke seizures and the associated factors among acute stroke patients presenting to Uganda National Referral Hospital, and specifics were to determine the 30-day incidence and as well as the factors associated in our setting. So again, why this study was needed in Uganda, we have a very high burden of stroke as alluded by the previous presenter, and almost about 26.4% that was done by Dr. Jen Nachibuka and al. in 2015. And we believe that since we have a very high burden, most of our patients actually get post-stroke seizures, but this the local data and evidence on this is very, very limited, despite our very high stroke burden. So this was the conceptual framework we worked with, looking at how the social demographic factors age, gender, residence, level of education, among others, and the clinical factors, like the type of stroke, is it hemorrhagic or ischemic, the severity of a stroke, where we use the NIHSS scale, mild, moderate, severe, and very severe, and then the neurological deficit, and length of stay, as well as the location of the lesion, and was there cortical involvement. Like most of these patients, most of the studies have shown that there are more post-stroke seizures among patients with hemorrhagic stroke, and most of these patients had an increased cortical involvement. And like the previous speaker alluded, so for you to consider a post-stroke seizure, you have to rule out other things that could actually cause seizures, and that's how we did some of that by ruling out patients that had hypoxia, patients that had hypoglycemia. We did a CBC to rule out any sepsis, because we have to exclude all the other causes of post-stroke seizures before you turn it as a post-stroke seizures. So all these we're looking at whether these patients are getting post-stroke seizures or not. So we used the George social model, which was helping us to develop how the post-seizures actually interact with the different social demographic clinical factors, imaging, as well as the medical and social history.